The views expressed in this podcast do not reflect those of our training institutions or the APA. The information discussed is intended for educational purposes only and should not be used for diagnosis or treatment. Enjoy! Hello, and welcome to American Journal of Psychiatry Residence Journal podcast. I'm Barrington Hwang, one of the media editors and currently a resident at Vanderbilt. We've got Robert McKenzie, currently a psychiatry resident at University of Texas Medical Branch.
Hey.
And Dr. Walter Wilson. Dr. Wilson served as a SAMHSA Fellow, was selected to serve as a panelist on the American Psychiatric Association's first town hall on structural racism, and has presented at the APA and American Academy of Child and Adolescent Psychiatry annual meetings. He's contributed to multiple textbooks and aspires to operate at the intersection of competent mental health care, patient advocacy, and mental health care policy and leadership. His focus includes Black mental health with a particular concentration and focus in Black males. So tell us a little more about yourself.
Sure. My name is Walter E. Wilson Jr., and I'm from Brooklyn, New York. I initially went to Howard University for undergraduate work and then stuck around for some graduate work there as well. Went to University of Minnesota for a Master of Healthcare Administration degree, and then back to New York, Stony Brook University School of Medicine, which I think has been renamed the Renaissance School of Medicine, which sounds pretty cool. Made my way to University of Cincinnati for adult training, 3 years, and then Vanderbilt for child and adolescent psychiatry training. Then Kentucky for my first employment opportunity with Health Point Family Care, which is a federally qualified health center in Covington, kind of right across the Ohio River from Cincinnati. So kind of coming back to the area, but things are good, just being able to help this population. It's the population that I always wanted to target when I, growing up and started to think about going into psychiatry. So be able to, get paid for what I wanted to do anyway is really good. I really enjoy working with the population out here. It's a population that, doesn't always have access to care. So to be a part of the movement that can change that is pretty exciting. So,
what exactly are the populations that you're working with?
So because it's a federally qualified health center, many of our patients are on Medicaid or are self-pay sliding scale, lower socioeconomic status of all different races and religions and creeds, and lower socioeconomic status doesn't discriminate when it comes to different types of people. So it's really just kind of lower income families that wouldn't, may not have access to mental health care for their youth. So it's been good so far serving that population. Providing substance use treatment as well has been pretty good for our facility.
When you're talking about some of the different communities that you're serving right now and working at a federally qualified health center, what are your main career goals that you were talking about earlier, and where do you see yourself going with that?
Of course, I'm a staff child and adolescent psychiatrist now. So my goal first and foremost is to be, as competent and as effective a clinician as possible. But I do have goals to move into administration at some point in my career, whether that be director of a behavioral health service line or a chief medical officer or director of a behavioral health care system. Definitely want to have an opportunity to impact institutional policy that helps treat as many kind of low economic status people as possible and minority patients as possible. So the goal is ultimately to go into healthcare leadership with in combination with clinical work and working in policy and advocacy, specifically mental health care policy with legislators to see if we can't work on some policy.
Okay.
So that's the goal. That's to be in a leadership position while also providing great care.
Sort of expanding on this a little bit, this year has been very reinvigorating discussion of minorities, African American roles in society and medicine. That is just as prime of a place where there has been a historic discrepancy and disproportionate care. Do you mind just telling us about your care for that in your career and maybe somewhat of this disproportionate factors may look like?
You hit it right on the head. One of my specialties, if not my main specialty, is just my interest in African American mental health, specifically the mental health of Black boys, adolescents, and men. That highlights a population in our country that disproportionately doesn't always have access to care. The evidence tells us when African Americans actually receive care, they tend to receive care of poorer quality for some reason. And when they present to a clinician, when it comes to mental health conditions as well as other kind of more general medical conditions, they tend to present with a more severe portion of their illness simply because they're coming to treatment late for various reasons. So committing a career to that is particularly important. And some of those disparities can be generalized to other groups as well, particularly the Latinx, Hispanic community demonstrates some of the same mental health care access and morbidity trends that Black population does. So unfortunately, we have a healthcare system that isn't serving all equally. And I think we're making positive strides to get to a point where there is more kind of equity in who has access to mental health care specifically.
Are there any ways that we as psychiatrists are strategically placed to sort of combat these disparities?
I think so, because the beauty of being a psychiatrist, and some can say the curse as well, or at least one of the challenges about it, is that we get to know people on a very deep level, which is a wonderful thing. But we're the ones who often hear the worst of the worst when it comes to what our patients are struggling with. And I think that gives us a unique responsibility to being emotionally, or at least from a clinical standpoint, emotionally responsible for individuals is a really big task. And that's not to take away from the other specialties. I think they do a wonderful job, taking care of what they went to school for. But I think psychiatrists are uniquely trained and skilled to work with the emotions of individuals, which it's hard to think of any population that doesn't deal with difficulties with emotion. And because of that, dealing with mental health is not a partisan issue. It's not whether you're wealthy or you don't have a lot of money, depression may hit you just the same. So I think mental health professionals have the opportunity to work across the lines and kind of be in the center of helping everyone really with a lot of things that are going on in the country, and just a very unique position because it's something that impacts everyone regardless of who you are. So I think when we talk about societal change or mental health policy change, there should be psychiatrists at the head of that table working with other mental health professionals to make sure that our populations are taken care of from an emotional standpoint. It's such a unique position to be in because patients are vulnerable with you, and that's a lot of responsibility for us to take on, and you should be proud of that responsibility.
You sort of hinted at in there, psychiatrists being in the middle of the table because everyone is our patient, everyone has emotions. We're better trained to take care of those symptoms. And sort of the other side of what we've talked about so far is the role of police officers is also a topic of discussion this year, and their role in our society, and a lot of things are changing. What are some things that psychiatrists and especially maybe us as residents can think about regarding those roles and in a mental health setting and how we can help affect that as well?
I think as psychiatrists, the first thing is to understand the state of America and law enforcement just in general, like understanding where the disparities are. And like, for example, political social climate we're in now, there's a lot of social justice work around African Americans and interactions with law enforcement. And, when we think about incarceration, right, African American males make up 7% of the population, but 40% of the males incarcerated in the U.S. And that's shocking, right? Or we think about, again, Black males being 7% of the population and representing 22% of the individuals killed by police, on a yearly basis. And that number is usually pretty steady. And that's not to ignore Breonna Taylor in Louisville. It's not just Black males. It's Black females as well with the Say Her Name movement. should move in unison with the Black Lives Matter movement, because Black females are also killed by law enforcement at a higher clip. But so I think when it comes to the role psychiatrists can play, the first thing is understanding which populations are, I don't know if we want to put it, are having difficulties with interactions with law enforcement. And again, similar to what I mentioned before, in addition to African American communities, it's important to recognize other groups, Latinx, Hispanic communities, and the like, American natives, groups that are historically oppressed by kind of the law enforcement branch of this country. So I think first is understanding what groups are vulnerable to this, and then understanding that I think one of the challenges, especially myself as a Black male who's also a psychiatrist, is understanding that we don't have to pick a side. I've spoken on police brutality and Black males in the past on a national stage. And, my mentality is it's okay. It's very much possible and acceptable to be anti-police brutality without being anti-police, right? And I think a lot of healthcare professionals or psychiatrists feel like we live in a country right now that's set up where you have to choose, and you actually don't have to choose. As a mental health professional, we know that not only is there mental health care impact of the killings of unarmed or armed African Americans, but there's also a lasting impact on police officers when those things happen. And we need to look at that as well. So I think psychiatrists are uniquely positioned to play a role of bridging the emotional gap between the communities that are struggling with relations with law enforcement without feeling a need to pick a side, because there is detriment to both populations when these disparities exist. And I think people need to make sure that we recognize that. So I think psychiatrists, as specialists in this area, in the mental health impact of traumatic events, we are the experts in the room when it speaks to, when we need to speak to the impact on white America, the impact on Black America, the impact on all populations when these things happen in our country, because they tend to impact people in different ways. So I think mental health professionals can offer training and offer education and play a really, really strong role in making sure that we know, or making sure that people know exactly what type of mental health ramifications can come from these things without necessarily having to pick a political or social, quote unquote side. Does that make sense?
Right. It totally does. And I agree with you. We as psychiatrists often treat a wide range of people, and maybe what we're treating is hard for us to not take personally or interact with at times, and just realizing that you're treating this patient rather than, like you said, the political leanings, the things that are said, is we're in a unique position to do that because we have so much experience in many different situations with that. I was wondering if you could maybe sort of expand for a little bit more about how trauma has a big role in this, because every side can agree on one thing, not to try and push this into sides like we were talking about, but everyone in this situation is affected by trauma. And maybe it has different ramifications, different effects, different resources. But what do you think that trauma as a factor plays into this, and how we can, as psychiatrists, can incorporate some of the understanding of that?
Yeah, that's a great question. Trauma plays a huge factor in what's happening in the country right now. And again, like you said, psychiatrists and psychologists, the whole mental health field, we're experts on understanding how trauma impacts our immediate behavior and emotions, and the emotions that we may carry with us for years to come and pass on to our children and things of that nature. And one of the books that talks a little bit about trauma was written by Joy DeGruy, who wrote a book called Post-Traumatic Slave Syndrome. And it's an example of understanding our interactions in society with one another through the lens of what you've been through in the past and trauma, understanding that some of the things happening in society now are maladaptive behaviors born out of a history of trauma. And when we talk about some of the things happening now, whether it's issues with law enforcement or just a myriad of issues that go on in our country, trauma is often at the forefront, because it's hard to have the types of events we've been having when it comes to Black Americans or when it comes to minorities feeling oppressed, just the history of this country, and then getting to 2020 and forgetting any of that has happened, right? I mean, it's very difficult to look at what's going on in our country without putting it in the lens of trauma, just because many groups in our country have been traumatized over centuries. So, and it's interesting, again, because there's data that looks at what is the effect of communities in the months before and months after the shootings of unarmed Black men. And we know that actually has led to, and I would love to see these type of studies repeated, but at least in one case, the increase in number of poor mental health days for Black Americans around the time of shootings. There was, and I want to say it was a study by David Williams. I believe he was the first author on this study, and I believe the study came out in 2018. But it talked about causing 55 million excess poor mental health days cumulatively associated with some of these events. But they looked at the impact of these killings of unarmed Black people. And there was a metric where the mental health of white Americans actually was not impacted as much. So, and now the question is, how do you interpret these things, right? We know that white Americans are impacted by some of these things. You know, when we have marches and we have protests, when it comes to this specific issue, there are a multitude of different colors of people there, which is a beautiful thing. So I think there is a lasting impact. To me, that's a study that's looking at trauma. It's looking at how has a community been traumatized or not traumatized by some of these events. And as psychiatrists, we can step right in there and be able to say, hey, developmentally, this is grief and this is not grief, and can kind of lead the way in understanding like, okay, well, when these things happen, they impact everybody in different ways, but trauma is often at the center of those ways that people respond to these type of things because they're traumatic events. I mean, it's common sense to kind of think of it that way.
That's interesting that you said how many people worldwide were affected by these shootings. And it might seem odd to some people that someone so far away seeing this through the news can be affected. And I feel like there's a big role for psychiatry and advocacy there, because even for other doctors, it's hard to understand our little patch of medicine, physiologic effects of perception. And the brain is the only organ that does that, can have pathology from something they perceive that is happening so far away and have long-lasting true health effects. Any other questions to deal with the topic?
I know when we were talking about police, people saying defund the police, and that's a polarizing statement. Could you comment on why it's not just as simple as that? What do you think could be helpful for this current structure that we live in?
Right. And you hit it on the head, right? It's a very kind of controversial, polarizing thing. And at the outset, it's very important for people to understand that, I mean, there are never one or two sides to an issue, but there's usually more, to be honest with you, especially complex issues. But when we think about defunding the police, there seem to be two kind of camps, right? One camp is divesting funding from the police and investing it in communities is one way of kind of thinking about it. So defunding the police in that sense is more pulling money from the police budget and putting it into communities, like sharing that money with communities. And then there's another camp that talks about like really defunding it, more of an abolitionist movement to defund police, where it's like you dismantle police departments and just build something else from the ground up. And those are controversial, obviously, because of one thing I will say is I think one of the disheartening things is that the Black Lives Matter movement has turned into an either or kind of movement, not necessarily of their own fault, but just in the psyche of America, it's Black Lives Matter or Blue Lives Matter, right? It's almost like those are opposing kind of forces, kind of banging heads against one another. When again, it doesn't necessarily have to be that way. And I bring that up because this particular issue falls in line with you're on one side or you're on the other side. I think it's most important, and the money is the issue, right? Where does the money go? We talk about defunding. The biggest issue is where the money is going. My biggest thing is how do we balance? Again, thinking of this as in me being a Black psychiatrist, Black male psychiatrist makes it tricky, right? In terms of me trying to think of this as a Black male or a Black male psychiatrist. But the reality is that movements are about generating allies, not being more divisive. Whatever issue we're trying to bring forth, how do we tie it to that central principle, which I think is important for any movement. Any movement out there, to me, a movement is about generating allies and not necessarily being more divisive. With regard to financially defunding the police, I think it's most important. I personally don't care where the money comes from, right? So I think part of the biggest issue is talking about taking it away from police. That's kind of like the biggest thing, right? That's what people fight back or are defensive about. And I think that's almost a non-issue. As long as what we need to do is educate law enforcement, change when it comes to dealing with certain communities, change the way the system thinks about that community, right? And that's hard to do. One could argue that the law enforcement branch of the U.S. has been weaponized against the Black community since the inception, right? I mean, it's just a reality that whether it's locally or whether it's federally, over the history of African Americans being in this country, in some way, African Americans have been oppressed by that particular branch of our country. So it's very difficult to put in something that actually changes the structure of how how police can view those communities. For example, I grew up in the 80s, right? And something in the 80s that I used to always see, which was commonplace, were cops walking the beat. Right, they would be in pairs and they would be walking around the community, and it actually kind of helped us get to know some of them. Right, but more recently, you don't see that as much. You see kind of, at least I don't know where they would still do that. I'm assuming somewhere in America they still do that, but it's more so you see cars, cop cars driving around, but they don't necessarily walk through the community. So how can we get that? But I think in that came a divide between law enforcement and some of our more vulnerable communities that have now grown to distrust law enforcement. And in many ways, vice versa, law enforcement has grown to distrust those communities. So how do we bridge that gap? So I think the funding of where we invest in our communities, I could care less where it comes from, as long as there's a budget for it. So I also had the Police Athletic League when I was younger, right? These are community organizations or community events that were, I don't know if they were funded by police, but Police Athletic League was on the front. That's was on the front of our shirts playing basketball. So there was a little bit more of a connection. Not that things were great then, but I think there have been changes over the last, I can only speak for when I've been alive, obviously potentially longer than that, but since the 80s when cops would walk the beat and you could say, "Hi, Officer Johnson," like that no longer exists where I live. I don't see police officers walking around as much. And I think because of that, for many communities that are currently distrustful, there's no way to build those relationships. So I think we need to invest in different community events that bring those communities together. And I don't personally care about where that funding comes from. But to answer your question directly, I think it's a polarizing issue because it's just inherently the idea of taking money from one thing and putting it in another. And those two things sometimes politically and socially in opposite. When they should be in tandem, I think that makes it hard. But specifics, we need to make sure that on one side, police officers feel equipped to deal with the settings that they're put in, right? So why should there be police officers 100% on the scene when there's a mental health crisis? I'm assuming they get a lot of de-escalation training, but why don't we have social workers? Why don't we have medical professionals or crisis workers or the like that are able to accompany police because the reality is that we need police in general. And we definitely need police if there are individuals who are potentially violent. But the reality that have mental health or a mental health crisis, they can be there because their job is to protect. And we have to respect police officers for doing that. But I think some officers are put in positions to where they're kind of deployed to these issues that they probably shouldn't be primarily involved in. So it's making sure police officers are put in the best position that they can to reduce negative outcomes and to make sure that communities are invested in to bring those two groups closer, and also getting the right professionals involved in things that often lead to negative clashes. But you also have to think globally. Like when we think about the objective of the whole, restructuring the way police interact with communities, the bigger issue is investing in community-based programs that do other things, right? Create better opportunities for education and employment and housing. I mean, the connection between poverty and these things. I mean, my answer is somewhat long-winded, but it's because it's such a complex thing. But to break it down, the funding, don't care where it comes from. It just needs to be invested in the community so that there can be more positive interaction between law enforcement and African American communities or Hispanic Latinx communities, where there's a lot of distrust. And the beauty of psychiatrists and social workers and psychologists is we understand how to have healthy interpersonal connections, right? We're trained on that. We're trained on, relationships and how to have healthy relationships. So we should be at the forefront of working with these communities on how to bridge these gaps. And it's going to take a lot of time. We got into these issues over, a very, very long, extended period of time, but we have to make sure these communities are invested in the way that they should be, and that police officers are put in positions for them to succeed, and also they have the right training on how to manage certain things with the appropriate supplemental staff, social workers, etc., to handle those more unique things that should be primarily responsible for. And I think doing that could start the process of bridging the gaps between those communities. So.
Awesome. Thanks for sharing that with us.
Yeah, thanks for a great explanation.
Yeah. Did you have anything to give advice for any trainees that are thinking about advocacy and these solutions?
Yeah, I think just understanding what the stats are, understanding who the vulnerable populations are, and just not being afraid to bring your expertise to the room, right? Again, we are the experts in emotions and behaviors and interactions between people. That's what we're trained on. So why can't we be at the forefront of interactions between entities in this country, communities and things, and just not being afraid to embrace being the expert in the room in that area, and then being open to different opportunities and different opinions, because again, we're playing the middle. We can strongly advocate for communities, as well as strongly advocate for our police officers to be trained and respected and understood. So I think we have such a unique position that other people don't, because we are experts in that area. So just not being afraid to embrace that.
Hey, well, thanks for sharing a bit more about what advocacy really means in the situation and some things we can do on the ground level we were asking about earlier. I know me personally, I'll keep these in mind in my training, and we'll definitely share it with others. If you have any thoughts you'd like to share, come visit us on Facebook, Twitter, and YouTube or Instagram. In the next episode, we want to discuss more minority mental health in schools, as well as other recommendations involved in these important matters.
The views expressed in this podcast do not reflect those of our training institutions or the APA. The information discussed is intended for educational purposes only and should not be used for diagnosis or treatment. Enjoy! Welcome back to the American Journal of Psychiatry Residence Journal podcast. I'm Barrington Hwang, one of the media editors and currently a resident at Vanderbilt in psychiatry. Again, we've got Dr. Robert McKenzie, currently a psychiatry resident at University of Texas Medical Branch, and Dr. Walter Wilson joining us again. Last time we talked about advocacy and how that relates to minority mental health. This week we plan to talk about child and adolescent populations, schools, and other considerations for trainees. Get us started off with our second topic.
Sure. You've hinted of trauma in childhood, adolescence, especially in minorities, and people express emotion or symptoms from our point of view differently, and they might be caught in different stages on top of that. Something that is happening in Texas is called the Texas Child Mental Health Care Consortium, and it's a bunch of institutions basically get a lot of funding for a few things, but among those, it's going to be like psychiatrists in school, on call for pediatricians, and research into trauma. And when I think of this, I think of me sitting in one of these schools trying to help or even doing the research. And then I also think of the historic discrepancy, specifically within psychiatry, of understanding symptoms, of discrepancies in diagnoses, like overdiagnoses of maybe bipolar now would be maybe be switched to DMDD, schizophrenia. And so talk to me a little bit, me and Barry, about if we're a psychiatrist in one of these rooms and if this program has just started and a young African-American male is sent to us instead of a cop, what are some things that we can do on just a ground level to better help take care of him?
Yeah. Being in schools, I think, is such a rewarding thing because you get to see kids in their own element. It's part of the reason why I wanted to work at a federally qualified health center as opposed to somewhere else. It's such an important thing to see kids in school because you get to see them where they learn and you get to kind of get an understanding of just a more natural place for them to be. So it's much more of a good picture of how they function because the main job for children is their school, right? We go to work and they go to school. That's kind of primary responsibilities for kids. So as a clinician, one, respecting that we're in their environment, but it gives us some clues into what that young man coming into your office may be dealing with. I think for an African-American male, I think one, understanding that all African-American males, and I say African-American, but it's really Black males, right? We have Black males from all over who don't necessarily identify as African-American. They may be Caribbean-American. They may be consider themselves to be more African, but they're all Black, maybe dealing with similar issues because of the country that we live in. So I think first thing is to recognize that African-American getting to you is a very important thing because kind of like you mentioned, or you kind of alluded to, African-American young boys in school who demonstrate aggression and anger are much more likely to be sent to the justice system than their white counterparts who are more likely to be sent to mental health care treatment. So understand that you have a golden opportunity when you do have a Black male in your office that has not been suspended or expelled or sent to the juvenile justice system as a response to what we in psychiatry often recognize as emotional disturbance. So to recognize that kid in your office is at much higher risk of not being in your office than being in your office. So, but I think starting off is just getting a sense of what that child is struggling with. I've been surprised. You can't assume, just like with any patient, like what their home life is like, what their functioning is like, which is usually grades and interaction with teachers and interaction with peers, interaction with family, but understanding the social context of that Black male. So one of the things that I think we often miss that's particularly important for Black males is what environment do you live in? Like, where do you live? Do you feel safe where you live? Is there gang activity where you live? Is there excessive poverty where you live? Because we know that these things often lead to, right, when we talk about complex trauma, the concept of complex trauma as opposed to the more general understanding of PTSD, right? PTSD is DSM-5 criteria based on usually one event that either happened to you or happened to someone that you care about. And now you have, or that you know, or that you may not know, but happened in front of you. And now you're having residual symptoms because of it. But what we often see in our minority children, especially Black males, Black youth, we see complex trauma. Complex trauma is chronic, everyday trauma, whether that be lack of resources or exposure to poverty, exposure to violence. Those are the things that a young African-American male may be presenting with that others are not presenting with, simply because poorer neighborhoods are more likely to inhabit minority individuals. So making sure you understand the specific nuances, the specific things that may be culturally important to that Black male, and sympathizing with whatever is going on. first understanding that not all black males coming into your office are going to be struggling with race-based issues, right? Their families might, and it may be trickling down to them, but that may not be their core source of struggle. But another thing is, if that is their core source of struggle, even if you are not a non-black clinician, not being afraid to help that young black male process that, because what we know is that when it comes to unique things about black males, and this could be black youth, but we're talking about black males specifically, when a black male is struggling with racial identity, what his place is in the world as a black person, as a black male, racial socialization is often protective against any adverse mental health outcomes. And racial socialization is usually something that's done within the family, but it can also be done in a therapist's office or a psychiatrist's office in conjunction with what's done in the family. And it just means that you process with that young black male what his sense of being a black male in this country is, and helping him fortify his racial identity. That's protective, as opposed to a young black male that's struggling in, say, an all white school, or even in all, a majority black school, and they just they're not coming to terms, or they're struggling coming to terms with some of the things that are happening to black males around the country, or in their neighborhood, or in their house. So I think not being afraid to discuss those things, even if you're not an expert in it, learn about that person, jump into literature and things of that nature. Also, and this will be my last point on this, but it's an important point, is when you have a black male in your office, understand, just like with all children, because I think we tend to drop these kind of criteria when it comes to black males and black females in our office, is understanding that there's always a reason for behavior, with rare exceptions. If someone is psychotic, then that's different, or if someone's manic, that's different potentially. But if you have a young kid, and most kids are presenting with behavioral difficulties, right, emotional and behavioral dysregulation, understand that black male may be is acting out for a reason, potentially, and not being quick to diagnose, but being quick to understand. So I think that's why there's such a knee-jerk reaction to call a security officer, as opposed to have that young black male sit down with the school counselor. There's that fear of young black males in the school setting, expelled at higher rates. Their punishments are more severe. I mean, the evidence is just clear that there is absolute fear of our young black males as they develop into men. And as psychiatrists, we have a very important responsibility to stand up against unnecessary referral to the juvenile justice system when we can identify a black male that may be acting out because he has depression or because he's extremely anxious, right? We have to be the ones that say, oh, well, in fact, black males tend to present with more somatic complaints, and you didn't let them go to the bathroom, so this is why they may have acted out, right? We have to be the ones that dig when others, based on either implicit or explicit bias, are much more likely to react with anger and heavy-handedness when a black male requires the opposite, just like any other individual that steps into our office. So, my advice to black and non-black professionals is to dig, because I think we forget to do that for some reason with our black males.
Right. And a follow-up question that I have been wondering, a part of that digging is understanding. And as psychiatrists, it's important for us to go across that role from sympathy to empathy, which takes a lot of knowledge, digging, understanding. Are there any tools, resources, literature that you specifically would suggest for us to do that, and so that when we're presented with such a case, it's easier for us to fight for patients like that and understand them, be there with them?
Great question. I can think of a couple things. One is, as clinicians, we always look to the literature, right? If we're unsure of where in the algorithm we are for treating major depressive disorder, we jump on PubMed, we find some articles, we go to treatment guidelines. The same thing can be said for a young black male or young black female that's in your office. Dive into the literature, right, and understand how this population presents clinically when it comes to mental health, or as much as we know about it, because one of the major issues is that it's very difficult, been a challenge with African Americans for many different reasons to get into research. But one tangible thing is to find the resources. One is PubMed, to look at what we know clinically about presentation, outcomes, things of that nature for Black youth and Black adults. More specifically, things like the American Academy of Child and Adolescent Psychiatry have a racism resource library full of clinical resources that help you talk to young children about racism, understanding racism and mental health in the African American population, just really great resources to gain an understanding of how you can start to have those conversations with an African American young patient that may be in your office. And the same thing can be said about the American Psychiatric Association. The current APA president has a task force that's addressing structural racism throughout psychiatry, also looking outward and how our patients struggle with racism and the mental health impacts of that. And there is really good racism modules at the APA that you can use to learn. There's several books, Social Determinants of Health. Black Mental Health was a book that came out in 2018 that helps us as psychiatrists understand some of the nuances, the cultural nuances of mental health care, diagnosis, and treatment of African American patients. But I mean, it's full of articles and that I think could, in websites and books that could be helpful in just understanding the experiences of the Black population and being able to take that and do good clinical work with these populations. So ACAP is a resource, APA is a resource. PubMed, of course, is much clinical, information that we have on African American populations. And then a secondary or equally as important is asking a Black colleague. Reach out to a Black colleague and that doesn't mean they may have the answers, right? But reach out to a Black colleague if you're struggling with a therapy case or not even struggling with, if you have interest in a therapy case or a medication management case with a Black male or Black female, whether that be a boy, man, girl or woman, and just in being able to pick their brain about what their experiences are treating African American patients. I would love if colleagues came to me and asked me about what are some of the nuances of treating African American males. Now, we know that African American males are not a homogenous group, right? They have different experiences and all that stuff. So the beauty about psychiatry is it's tailored to the individual. But I like to call them cultural consult. If I had a Native American or American Native patient, and I happen to have a Native American colleague, I would really reach out to that colleague, right? And same thing with African American males or African American youth. So utilizing those resources that you can find, reaching out to colleagues. The APA Black Caucus is another resource if you have interest in the topic and want to learn more. Same thing with ACAP Black Caucus. So there are a lot of resources out there to be able to learn more and know generally how to approach African American population while also tailoring to their specific experiences.
Great, thanks. Yeah, those are some really, I think, solid, tangible resources that will really help. And you listed a lot of them. And so thank you.
Of course. Absolutely.
Yeah, Walt, growing up, I remember last time we talked about some of the police in schools. When you were in high school, your school, the atmosphere changed a little bit. In the middle of your high school experience, there are police officers placed in your school. Could you just talk about some of your own individual experiences, maybe of your peers in that environment?
Absolutely. I went to a school called A. Philip Randolph High School in Harlem, New York. And during my time there was a kind of a change in the way security was done. So I can't remember if it was my sophomore year or my junior year, but things changed to where every student coming in the building had to come in the front doors and kind of put all of your stuff down on the table, like empty your bag. And we had to go through metal detectors. And then there were New York City police officers placed in the school where previously there were, the more general kind of security officers. So it changed the dynamic. And I think as a kid, 14, 15, however old I was at the time, I know how it felt. It felt weird. It felt like we were almost like walking in as prisoners. I mean, you think about that. Not every school in our country has 14, 15-year-old kids who have to experience that kind of thing, right? To where before you even walk into your classroom, there are signs that we have to make sure you're not a criminal. That's a very kind of difficult thing to grasp, as you go into calculus class. Before you even do that, before you even open a book, they're checking to make sure you don't have a gun. So now the challenge is, how do you keep kids safe without kids feeling like prisoners? Because again, I know how that felt to me, and I know that our parents weren't very happy with that. My high school experience was great, but I think, that does make you feel, as a school that's, mostly or half and half African American or Black and Latinx and Hispanic, that sent us a message that, at least from a safety standpoint, we couldn't be trusted. So it was very difficult for me to process that as a Black male, trying to understand like why that would have to be the case every single day. Like what changed? Why did that happen? So, but at the same time, I had some good experiences with the police officers who were there. Again, you go from security guards who aren't carrying weapons to police officers who are carrying weapons in our schools. As I remember it, again, that was a long time ago. So, again, it changes the dynamic. It's a really difficult thing to think about in inner city school, having to or have that as a safeguard, in the dichotomy of that experience with the good academics experience and enjoying time with your friends. But it definitely put in the back of your mind, at least somebody thinks you're a criminal potentially. It's hard to separate that at 14 or 15. So that was not a good experience. Now, when we have students who are struggling with the same things or same things happening in school, where you have to go through metal detectors and all that kind of stuff, compared to a student who's never had to do that. Those are two very different experiences, and self-worth can be impacted by those things. So something that had to be processed as I got older, and separated whatever anybody else thought of me from what I thought of myself.
Thanks for sharing.
Yeah.
Do you have any kind of lasting thoughts or advice for trainees with regard to populations in schools? Do you have any other thoughts?
As a trainee, I really enjoyed, a child psychiatry fellow at Vanderbilt. I really enjoyed our in-school clinics, and you all have that opportunity to do that. I really encourage, having that experience. It's almost like having a home visit as a physician, right? You get to see and feel an environment that otherwise you wouldn't be able to help. You wouldn't be able to experience, and thus contextualize the patient differently, right? If you have fear walking through a neighborhood to get to a school for your clinic, imagine what that 7-year-old may be experiencing. As far as in schools, just understanding that when it comes to African American children, that is a gateway to getting to clinical care that not all children have. Many of the kids in my school clinics were selected by Vanderbilt because they had the least access to care. So understanding that you have such an important role in that school, and to take that seriously, and just understand that you're a part of that referral, so you're a part of that gateway to that child getting care that they may not otherwise get. And I kind of liken it to mental health ministries in churches, which I'm going to be working on here in Kentucky. But that's another gateway to getting people to treatment. Being able to get those windows into where a kid learns, how they learn, what their teachers are like, what the school environment is like. And it is such an incredible opportunity for trainees who, to be honest, are very much used to being, almost in ivory towers, where you're in your office or you're in the hospital and patients come to you and they're on your own terms. Now you get to see patients on their terms and in their environment. And also understanding that patients respect you for it and love you for things like that, and really respect you for things like that. Because not everybody comes to their environment. Not everybody cares to come to their environment, especially psychiatrists. We're way too often kind of walled off. Understanding that that's an incredibly important point of care for many of our Black youth. Treat them the way you would as if they were coming to your offices. So such an important point of care.
Awesome. Well, thanks so much for sharing your thoughts and your time with us.
Sound good? Mm-hmm.
Yep. Thanks for having me. This was great. I learned a lot and had a great time.
Definitely. I had a great time as well. I appreciate you all having me on.
Okay. Well, again, thank you. We really appreciate coming and talking with us, Dr. Wilson. We definitely need more people like you to help us examine how we can address these topics in advocacy, child and adolescent populations, and also things we can do from here on out. We appreciate your thoughts as one of the leading voices regarding Black mental health.
Thank you all again for listening. The AJP Residence Journal podcast will also take a break over the holidays and resume back in mid to late January. Stay safe and healthy out there.
If you have any thoughts you'd like to share, come visit us on Facebook, Twitter, and YouTube or Instagram.
Yeah, I think that's all we got.